Fundamentals of International Health. So why should you learn about international health? Well, it is important to know about it because the world is flat, so to speak. With increasing globalization, with commerce, information technology, international travel, and worldwide job opportunities. Increasingly, people living in Bangalore and Hyderabad are required to travel to US, Europe, Australia, and even Africa to work for their multinational companies. Also, with increasing medical tourism, it is becoming imperative to know about health conditions. Also, one can appreciate the health standards in India better if you have an international perspective. So, welcome to this introductory talk on international health. I am Dr. Fehmida, Iyer, Visnegarwala, your course faculty. Each topic covered in this talk will be dealt with in such much more exciting detail in the full course to follow, so stay tuned. So first we have to understand what is health. The World Health Organization defined human health in their constitution as a state of complete physical, mental and social well-being and not merely absence of disease or infirmity. Global health can be defined as encompassing health problems, issues and concerns that transcend national boundaries and may best be addressed by cooperative actions, and may be viewed not just as a state, but also the goal of improving health for all by reducing avoidable disease and disabilities. Now, the one most important organization which you need to learn about is World Health Organization or WHO. The World Health Organization is a specialized agency of United Nations concerned with international public health. It was established on 7th April 1948, headquartered in Geneva. As of 2016, 194 member countries have ratified it. Since inception, it has played a key role in eradication of smallpox, first disease to be eliminated by human effort. Current priorities include eradication of polio, control of communicable diseases such as HIV, AIDS, malaria, TB, Ebola, mitigation of effects of non-communicable diseases. Also, the WHO is concerned with sexual and reproductive health, development and aging, nutrition and food security, occupational health, substance abuse. It is tasked with reporting, publications and networking. The World Health Organization's role in international health includes providing leadership to the world and member countries on matters critical to health and engaging in partnership where joint action is needed. To stimulate and advance work to eradicate epidemic, endemic and other diseases, shaping research agenda and stimulating the generation and translation and dissemination of knowledge, setting norms and standards and promoting and monitoring their implementation. Also, in articulating ethical and evidence-based policy decisions, providing technical support, catalyzing change and building sustainable institutional capacity, monitoring the health situation and assessing health trends. It is also concerned with civil registration and vital statistics. So, WHO helps member countries achieve health. But how do countries achieve health? It is through health systems, which includes all organizations institutions and resources that are developed to producing health actions. What are health actions? These are any effort, whether in personal health care, public health services, or through intersectoral initiatives, whose primary purpose is to improve health. Now, health systems have twofold objectives of good health, which is best attainable average level goodness and the smallest feasible differences among individuals and groups of fairness. Therefore, there are three goals of health systems: goodness, responsiveness to expectations of the population, and fairness of financial contribution. So, the definition of a health system consists of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. This includes efforts to influence determinants of health as well as more direct health improving activities. A health system is therefore more than a pyramid of publicly owned facilities that deliver personal health services. It includes, for example, a mother caring for a sick child at home, private providers, behavior change programs, vector control campaigns, health insurance organizations, occupational and safety legislation. It includes intersectoral action by health staff, for example, encouraging the Ministry of Education to promote female education, a well-known determinant of better health. So, health systems are mainly controlled by government. However, some countries such as India, private sector plays a major role. It encompasses both traditional and modern modalities of treatment, both preventive and curative care, and it helps to manage the health system using health policy and national health accounts as needed. Now, it is important to understand the different health systems. To understand that, we need to know how the health system have evolved. Traditional and indigenous systems of health have been present for thousands of years in India, China, and Africa. However, in 1883, Bismarck, the Chancellor of Germany, brought about state-mandated social insurance model where employers covered the health of their employees. Belgium, Norway, and then Great Britain followed suit. Slowly this model was adopted outside Europe. Japan and Chile adopted it. World War II destroyed a lot of health systems, but paved the way for Britain's National Health Service, or NHS, the most widely influential model of health system. New Zealand and Costa Rica had already laid foundation for universal health insurance. Various countries such as Mexico, Norway, Sweden, Chile, etc. adopted this model. India, post-independence, based on Boer report of 1946, adopted bold 5-year developmental plans. Now, in developing nations, health facilities and clinics had been built, but mainly in urban areas. These hospitals received 2/3 of all government health budget, despite just treating only 10 to 20% of population and conditions which could be managed in ambulatory care, such as diarrhea, malaria, and tuberculosis. Thus, there was need for a radical change for efficient, equitable, and accessible healthcare. This led to the rise of primary healthcare as a route for achieving universal health coverage which was cost effective, adapted by various countries with good outcomes. Primary health care provides minimal levels of health care, food, health education, safe water and basic sanitation, preventive versus curative health care and essential drugs. This led to the adoption of Healthcare for All goal in 1978 by WHO and UNICEF. A cadre of community health workers who could deliver cost-effective services in rural facilities to population which had no modern health care. India thus provided 2/3 of her health population through these community health workers. However, there has been a dissatisfaction with primary health care because of rising availability and quality of modern health care and increasing technology. Therefore, several countries have introduced universal health insurance such as the National Health Insurance or NHS of the UK. There also has been a mixture of health insurance and out-of-pocket spending. For example, in the United States, there has been a great shift of power from providers to insurers who now largely control the access of doctors and patients to one another. This above model of health insurance predominating in healthcare decisions is becoming prevalent in urban India as well. What are the different methods by which a health system finances itself? General taxation to the state, county or municipality, national health insurance, voluntary or private health insurance, out-of-pocket payments, and donations to charities. Mix of all the five models in most countries is prevalent. Now, how do countries get ranked for health? There are country-specific benchmarks. Status of any country is determined by the status of its vulnerable population, which is women and children. Thus, countries get compared by infant mortality rates, under 5 mortality rates, maternal mortality rates, malnutrition rates. One important benchmark is the longevity of life, which is life expectancy at birth. People may lead long lives, but the quality of life may not be good. So we measure disability adjusted life expectancy. Other benchmarks such as healthcare workforce, that is number of physicians per 1,000 population, number of nurses per 1,000 population, etc. are important. Another important benchmark is the healthcare expenditure per capita. Now, based on all of these rankings, here is a map of global health ranking. Countries in green are ranked the highest, which includes Canada, Australia, most of Europe, followed by US, Mexico, South American countries, followed by China, Brazil, UAE, etc. India is ranked 103. The countries in Africa, Afghanistan, former Soviet Union are ranked lowest in red. The global health ranking is reflected in one of its benchmarks, which is life expectancy at birth. Again, countries in green, the North America, Europe, Australia and Japan have life expectancy between 76 and 84, followed by countries in yellow. India, as you see there, is in pink. What I would like to point out is that overall, the health ranking in the world is closely linked to how rich the country is, as measured by gross domestic product per capita, as seen in this map. This is apparently because the richer countries spend more for healthcare. And more about this we will learn in the detailed course. Now I want to point out some interesting paradox in health system comparison with the healthcare expenditure. The GDP or the wealth does not always mean good health in terms of life expectancy at birth. For instance, even though the USA spends nearly $7,500 per capita for health, which is seen on the left bar on this graph, its life expectancy at birth is only 78 years, right bar in this graph. Whereas in comparison, Japan spends only 2,700 healthcare dollars per capita and achieves life expectancy of 83.6 years. With Norway, Canada, France, Sweden, Italy, UK, all of the countries in between. This graph shows the life expectancy in India as compared to USA and Japan from 1960 to 2015. As you see here in blue, the life expectancy in India was only 40 years in 1960 and it increased by 28 years in the last 55 years, which is no small feat considering we spend only $75 per capita for health. So there is a lot of inequality in health systems of the world. Low and middle income countries account for only 18% of world income and 11% of global health spending. Only 4% or less of the GDP in their countries. Yet, 84% of world's population live in these countries and they bear 93% of the world's disease burden. It is not just the government of the different countries which control the healthcare system. There are other players. For instance, the multilateral agencies. The funding for these multilateral agencies comes from various donor countries and non-governmental sources, and they work in several countries. Examples are the WHO, the United Nations Children's Fund or UNICEF, World Bank, Global Fund to fight AIDS, tuberculosis and malaria. Then we have bilateral agencies, where the funding comes from one country and the work is done in several countries. Examples are United States Agency for International Development or USAID, Centers for Disease Control or the CDC, non-governmental organizations. There are various international NGOs. Lot of the international health work is performed by NGOs including CARE, Medicine Sans Frontiers or Doctors Without Borders, International Committee for Red Cross, International Medical Corps, Oxfam, Partners in Health, Project Hope, Save the Children, Pakistan Heart Foundation. Now, to enable collaborative action in the world, in the year 2000, 189 nations made a promise to free people from extreme poverty and multiple deprivation. This pledge became the 8 Millennium Development Goals to be achieved by 2015. The MDGs are very broad and encompass many sectors, not just health. Of the 8 MDGs, the health-related goals are MDG 1 to eradicate extreme poverty and hunger. MDG 2 includes achieve universal primary education. MDG 3, which is to promote gender equality and empower health. Reduce child mortality is MDG 4. MDG 5 is improve maternal health, achieve universal access to reproductive health. MDG 6 is to combat HIV, AIDS, malaria and other diseases. MDG 7 is to ensure environmental sustainability. MDG 8 is to foster global partnerships for development. There are currently many challenges in international health. Due to widespread international travel, we have emerging and re-emerging infectious diseases such as Ebola and Zika. There are various other communicable and non-communicable diseases. The challenges on the world health and occurrence of natural disasters due to climate change and global warming. There is an enormous challenge due to food insecurity and poverty, leading to nutrition epidemics of both under and overnutrition. As the world economies change, there is increasingly more global urbanization. As there are war and internal conflicts, there is internal and external displacement, leading to a huge refugee crisis and all the problems related to that. The human population explosion is the world's greatest challenge. We have one planet Earth, but we use resources of up to 2.2 planets. And the greatest resource we are running out of is safe water for consumption and agriculture. You will learn much more about this and more challenges on international health in the full lecture to follow. Thank you.